Hello, I'm Dr. Linda Bradley, Professor of Surgery and also Vice Chair of Obstetrics and Gynecology and the Director for the Center of Menstrual Disorders and Fibroids, as well as hysteroscopic services at the Cleveland Clinic in Cleveland, Ohio. Today our topic is fibroids, new options in medical and surgical management. As requested, I'd like to show my disclosures as listed here, including Bayer, Boston Scientific, Medscape Advisory Panel, OBGYN Management Board, and I also receive royalties for my textbook on hysteroscopy, office evaluation, and management of the uterine cavity, published by Elsevier in 2009, as well as receive royalties from up-to-date chapters in hysteroscopy and operative hysteroscopy. Lastly, I also have received honorarium from ACOG Practice Bulletin on the management of abnormal uterine bleeding associated with ovulatory dysfunction in 2013. Today I'm happy to talk with you about something I love to speak about, and that is fibroids. So today we're going to cover the following 4 topics. We're going to outline the burden of fibroid disease and the rationale and need to individualize clinical care. Secondly, we're going to list all non-surgical procedural interventions for the treatment of uterine fibroids, as well as describe surgical options for the treatment of fibroids. And lastly, look at outlining emerging medical and therapeutic options. So when we look at fibroids, we know that they're prevalent, and as I describe it, as an equal opportunity problem. It is the most common non-cancerous benign growth in fertile women with high prevalence, significant health problems, and a huge economic impact. Certainly we know little about the etiology and pathophysiology of fibroid development, and much is being studied these days. We also know that fibroids are the most common cause of hysterectomy, that they affect 80% of women of the reproductive age, but only about 25 to 30% of women actually have clinical symptoms. We also begin to look at the importance of quality of life, how fibroid symptoms impact women, and about 25% of women will actually require treatment. Each year in the United States, there are over 600,000 hysterectomies and only 125,000 myomectomies. And each year, 1,000 women die from complications related to hysterectomy. A vast amount of money, $2.2 billion, is spent annually in the United States for the treatment of uterine fibroids. So what do we know about fibroids? There are lots of sobering statistics. For women from the African diaspora, there is a 3-fold increase in the relative risk. But the interesting thing about women of color is that they have a higher disease burden, earlier onset of symptoms, and the fibroids are much larger both in volume and number. Certainly we don't know everything about fibroid development, but some of the risk factors include early menarche, late reproductive years, runs in families, more often seen in women who are overweight and nulliparous, also among women who have polycystic ovarian syndrome, diabetes, and hypertension. Recently, Dr. Elizabeth Stewart and I, as well as Dr. Barra, was involved with a national survey. And what we did was to look at about 968 women who were surveyed. It's interesting to find out that women on the average waited 3.5 years before seeking treatment. And in fact, 41% of women saw more than 2 healthcare providers for reaching the diagnosis. The impact of fibroids was seen such that 28% of women missed work now and then. 24% of women believed that their symptoms prevented career development and their potential because of pain or heavy bleeding. And many, many women, in fact 79%, expressed a desire for treatment that did not involve invasive surgery. More than half of the women desired uterine preservation, and for women that were under the age of 40, 43% still wanted to have fertility and to preserve fertility. So as we begin to look at different surveys, please remember to think about quality of life, not only in the survey, but in how we impact and interface with our patients in the office. Our patients are concerned about their health, they're emotionally are concerned in terms of having concerns about their sexual functioning, body image, loss of control, and hopelessness. So when I see a patient, what do I think about? Here are about 10 things, and I'll just list a couple of them as I interact with my patients in the office, and hopefully you'll think about this too. So it's important when you see a patient to determine how do the fibroids actually impact her quality of life. Are the symptoms that the patient's having, are they really related to the fibroid? Could the pain be from adenomyosis, for instance, or endometriosis, or pelvic adhesive disease, or something totally different? It's important when we look at the types of symptoms that women can have, and as we marry the symptoms to what we can offer for treatment, always ask the patient what bothers her the most. Is it bleeding? Is it bulk symptoms? Is it fertility? Does she want children? Does she want to keep her uterus? And the symptoms, as we listen to them, we have to figure out, do they actually require invasive therapy, or are there medical treatments that can treat our patients? In addition, when we begin to look at other options such as surgery or uterine fibroid embolization or even MRI-focused ultrasound, are there anatomic factors that would predispose the patient to treatment failure or reoccurrence, or does she have all the factors in place that will allow her to have successful outcome? Additionally, if we're thinking about surgery, to determine are there medical or surgical risk factors that predispose her to anesthetic risk or surgical risk, or does she have increased surgical morbidity and even mortality? It's important, I think, especially at a tertiary care institution, to determine if you have an interdisciplinary team that you can work with to help evaluate and treat these patients. And for some patients, whether they're working in school, stay-at-home moms, it's important to notice and ask the patient about convalescence. Does she have time for a 2, 4, or 6-week recovery from surgery? So as we look at options for women, there are many options, but it really depends on the burden of fibroid disease. So for instance, is a patient a candidate for vaginal hysterectomy, more minimally invasive surgery, robotic, abdominal? As we look at the picture of the patient lying prone, we can see a large, approximately 20 to 22 week size uterus. And for many of us in our specialty, we know that this would not likely be able to be removed solely by the vaginal route. Are there other options such as uterine fibroid embolization, which is performed by interventional radiologists, as well as MRI-focused ultrasound? Are the patient's fibroids intracavitary in the submucosal location that would be amenable to hysteroscopic surgery or medical therapy? So as we can see from all these images here, size, number, and location of the fibroids might determine what option our patients may or may not have. And it's important when we look at our patients to determine what's in our toolkit. Do we have a multidisciplinary team? Do we have surgeons that are excellent vaginal surgeons, or those with advanced laparoscopic skills or robotic skills or hysteroscopic skills? Do we have the ability to work with our interventional radiologists? Are you a center of excellence? Do you have a dedicated surgical team that can help determine and individualize the care that can be offered to this patient? So equipment, as well as exposure to clinical trials for some emerging medical therapies, I think is very, very important. Approximately in 1992-93, uterine fibroid embolization became more popular and has increased tremendously over the last decade and a half. So what is uterine fibroid embolization? It is a procedure, outpatient procedure, that is performed by an interventional radiologist in which the uterine arteries are canalized. Small particles are placed through the uterine artery in order to block the flow of blood to the fibroids. And in so doing, it doesn't kill the uterus, but it basically infarcts and shrinks the fibroid. There is a differential in the vascularity between fibroids and normal uterine tissue that makes selective fibroid embolization possible. What happens after embolization? Well, it results in ischemic infarction such that there's decreased vascularity. The myometrium is spared, and the fibroids begin to shrink, usually within 4 to 6 months, but also over months and years. And both large and small fibroids are infarcted. So as the fibroids get smaller, the uterine volume gets smaller, and the patient will have hemorrhagic infarction and also hyaline degeneration of the fibroids. In general, the indications for uterine fibroid embolization would be for patients who are symptomatic in their reproductive years and do not want further childbearing. Perhaps the patient has had a previous myomectomy or has failed medical therapy. These would be great patients for the procedure. Maybe they have many contraindications, massive intra-abdominal adhesions, for instance, Crohn's disease, ileostomy, colostomy, all those kinds of things in which a surgeon may not want to go into the abdominal cavity. Emerging, we'll see some data that shows that uterine fibroid embolization, especially for women in their late 40s, has been helpful in women with adenomyosis. When we look at the contraindications to embolization, as we often say, we can't treat what's not broken. So the patient who is totally asymptomatic with fibroids should never be offered embolization. Likewise, a woman who is menopausal, whose fibroids begin to grow, we should not offer this therapy. Why? Because these are the women that we would be most concerned about having a leiomyosarcoma. If a patient has an active infection, pelvic inflammatory disease, prior history of pelvic radiation, if she has a life-threatening contrast allergy or severe renal failure or insufficiency, these too would be contraindications for fibroid embolization. As well as other contraindications include AV shunting, undiagnosed pelvic mass, patients who have a fibroid that's on a stalk, less than 3 centimeters. These patients should not have embolization because sometimes with embolization it has been shown, although anecdotally, that these fibroids may torse or twist off and then become an abdominal mass with resulting pelvic pain and adhesions and requiring secondary surgery. Women who are currently pregnant should not have embolization of the uterine arteries, as well as uncorrected coagulation disorders. It is a rare occurrence for a patient to have an immediate complication from uterine fibroid embolization, but if someone absolutely refuses hysterectomy for a potential complication, she too would be contraindicated. In 2005-2006, the Fibroid Registry began to publish information. And as a physician at the Cleveland Clinic, we were a part of that registry. There were almost 3,500 women that were enrolled at 72 sites across the United States. Excellent follow-up with the patient, almost 90% when we look at some of the data. So at 6-month follow-up and 12-month follow-up, we can see that patients turned in their registry, which listed complete information about quality of life, their symptom relief, and if they had additional surgical procedures. What did we find from the registry? Very, very small risk of immediate complication. Some of these patients may have a potential for prolapsing of the uterine fibroid. 2.4% of the patients were admitted for pain. And I would say that now in 2014, we are seeing fewer and fewer readmissions because we now have great cocktails of pain medication that helps keep our patients comfortable. But back then, again, about 2.4% were readmitted. Only 3 hysterectomies were performed within 30 days. And when we look at other gynecologic procedures within 12 months, only 5% of patients had additional procedures. So overall, the majority of patients had improved quality of life and health-related quality of life scores, just showing a great benefit from uterine fibroid embolization. So if we look at the world literature, and each year we get more and more data, but the data always looks the same. When we look at heavy bleeding, I tell my patients that almost 80% of them to 88% will have improvement in heavy menstrual bleeding. For the patients with a large uterus with pain and pressure and bulk symptoms, anywhere from 71% to 98% will notice less. So less urinary frequency, constipation, pelvic aching, because the fibroids will decrease in size on the average between 40 and 60%. Likewise, the publications show that yes, there are hysterectomies performed, but the good news is that hysterectomies for complications are very, very low. And these are just a few images of an MRI of a 53-year-old who had presented with heavy bleeding, pain, and pressure. And we can see the pre-MRI showing a fibroid almost to the patient's umbilicus, and at 3, 6, and 1 year later, we can see dramatic improvement in the size of this fibroid. And this is very, very typical. Additionally, our patients always ask us, Doc, how is this going to help our bleeding? Some of our patients bleed so much, I always say that it's almost like they bleed like Niagara Falls. But I love this particular study that was done in 2004 using the alkaline hemotin assay, a very, very deliberate measurement of blood loss captured from patients' pads and tampons. And what I tell my patients, as you can see here in this slide, by year 1, patients will decrease their bleeding by up to 80%. And the good news is that that improvement in bleeding or reduction in blood loss is sustained over time, in this study up to 48 months. What about size? Consistently, all studies, both international and national, show that volume of the fibroids decrease on the average by 40 to 60%. But I do want you to look at this equation that looks at the volume reduction of a sphere. So how do I use this information? When we look at a 10, 15, or 20 centimeter dominant fibroid and we say that it decreases by 50%, again, we're going from 10 centimeters to 7.9 centimeters for a patient with a dominant fibroid of 10 centimeters. Likewise, if she has a large 20 centimeter single dominant fibroid, it'll decrease to almost 16 centimeters. I use this information in the office to determine whether embolization would be helpful for a patient whose main complaint is a cosmetic effect. She looks pregnant. She can see her uterus filling the lower pelvis. Her clothing doesn't fit very well. So with a massively enlarged uterus, yes, it will decrease in size, but as you can see from this equation, it may not be enough clinically for her to be happy with the outcome. Interestingly enough, even with this reduction in size, if someone bleeds extremely heavy, their bleeding often gets much improved, where you'll see the size here may not decrease as much as you might think. Again, just remember this equation. What about complications? I gathered really the world's literature on looking at interventional radiologist complications from the procedure, and only 1% or even fewer of patients will have these complications as listed: groin infections, groin hematomas, arterial perforation, puncture site infection, a thromboembolic complication, contrast allergy, or contrast-related renal failure, AV malformation or pseudoaneurysm, or potentially misembolization of the vessels such that other organs are affected, and also radiation exposure. So our interventional radiologists, when they speak to our patients at their consult appointment, will go over this, but again, a very, very low rate of complication. And there have been pregnancies in women following uterine fibroid embolization. However, I really want to point out that this is not a procedure for women who want children. Why? The literature shows that there's a greater risk of miscarriage, intrauterine growth retardation or restriction, abnormal placentation such that the placenta is adherent and does not separate, leading to postpartum hemorrhage, higher rates of malpresentation preterm birth, and intrauterine synechia. Sometimes even amniotic band syndromes have been reported in offspring of women who have had embolization. When I also look at the world's literature for potential complications that a gynecologist would see, I'm also listing in this slide all of the things that are listed here, and overall the percentage of complications are low. Our patients now nowadays are actually ambulating sooner, so that the risk for a pulmonary embolism is present, but it seems to be less than more than a decade ago when we kept sandbags on the groin and kept women at bed rest. So many of our patients are going home in 6 to 8 hours or with a 23-hour stay in the hospital. However, if a patient comes back with shortness of breath, tachypnea, anxiety symptoms, do think about pulmonary embolism. For gynecologists, it's a low chance that we will need to do anything for those patients. But mostly it would be due to prolapsing fibroids or leukorrhea with a purulent discharge or pain, and so there may need to be a hysteroscopic procedure performed in order to treat that. Infection, systemic, local pyometritis, endometritis happens, but it's very low. The risk of embolizing other target vessels can happen, but it's very low, as well as the risk of premature ovarian failure. In fact, it's been reported as only 1 to 2% in women less than age 45, and 2 to 5% in women greater than 45. The risk of post-procedural pain, premature ovarian failure, not able to have an orgasm, death, and also the delayed diagnosis of leiomyosarcoma. Very, very unlikely complications that we will see as GYNs. So in summary, for uterine fibroid embolization as a treatment option for women, we know that it has, it's no longer considered to be experimental. It is covered by insurance companies. It has been shown to be effective with durable symptom relief. There have been more than 500,000 procedures worldwide. And each year in the United States, about 35,000 procedures are performed. As we look at the world's literature, between 80 and 95% clinical success as it relates to bleeding and relief of bulk-related symptoms. And many clinical studies show equivalent symptom relief compared to surgery with less recovery time and complications. Increasingly, we're finding shorter stays, as is common with many procedures, and a less than 24-hour stay is seen for most patients. In some places around the country, just a 6 to 8 hour stay. Most of our patients can actually return to full activities in about 1 to 2 weeks. So these are all the things that I would share with you about uterine fibroid embolization. Focus ultrasound is another emerging possibility for the treatment of fibroids. So what is MRI focus ultrasound? Basically, a patient lies on a table and there is an MRI image that's done under real time, and the fibroid is heated to 60 to 65 degrees. The other tissue is not heated, and with the heating leads to coagulation and necrosis of the fibroid. Selection for patients for focus ultrasound are again in pre or perimenopausal women who have symptomatic fibroids, no contraindications for therapy. Generally, we look at symptoms like pressure, urinary frequency, or bleeding, and to rule out all other things, MRI imaging is performed before. If the patient has heavy bleeding or uncertain bleeding, endometrial biopsy should also be done, as well as hysteroscopy to exclude endometrial pathology. The next few slides are just going to look at patient selection. And in this slide, we see very, very large fibroids, both at the top, right and left, and at the bottom. And in here, the important take-home factor is when the patients are treated, immediately after treatment, we want to look at what's called the NPV, or non-perfused volume. It is an important predictive factor for the treatment and durability of symptom outcomes. So this was a patient who was 48, had heavy bleeding and bloating and frequent urination. And what this image is showing that the patient had a non-perfused volume between 68 and 86%. And that's really a good outcome because the fibroids began to shrink, her quality of life scores we can see improved, and her symptoms overall improved because the fibroid decreased in size. What the take-home numbers show that the more that the physician can treat the fibroid so that there is less blood flow, such that the patient has higher rates of necrosis, that the quality of life scores, quality of life scores improve, and fibroid volume decreases, as seen in this graph. And again, looking at almost 359 patients with a 2-year follow-up, when the non-perfused volume is high, greater than 60%, we see less and less need for additional treatment because the patients have excellent outcome. And this is showing outcomes between 12 and 24 months. Again, looking at symptom relief at 3, 6, and 12 months, symptom improvement between 85 and 87%, and very few patients had worsening of symptoms. So again, it's important that the non-perfused volume, once you have a higher rate of non-perfused volume, hence necrosis, that the patient's symptoms get better. What about side effects? Very few. Most of them are transitory, where the patient may have some nausea or vomiting. Less frequently, they may have some swelling, abdominal cramping, vaginal bleeding, or even difficulty urinating in less than 10%. And less than 3% may experience first-degree skin burns, as well as pelvic discomfort. Very, very rare, less than 1% with second and third-degree skin burns or neuropathy. There's a whole lecture that we could give about ways and methodologies to decrease these complications, and that would be for another lecture. More and more physicians are learning great techniques in order to limit any effects of organs near and around the fibroids, such as bladder, such as adhesions, or bowel. There are pregnancies following MRI-focused ultrasound that we can see here. Most of the patients are delivering vaginally, and very, very few patients have had complications, and most of the babies are delivering at term. As we look to the next treatment options for women with fibroids, recently FIGO looked at a classification, I should say, of uterine fibroids. For fibroids that are fully intracavitary, known as type 0, less than 50% involving the myometrium is type 1, and when more than 50% of the fibroid involves the myometrium, we call it type 2, as well as the location of other fibroids, with type 6 and 7 being more traditionally thought of our exophytic fibroids. We know that fibroids that are in the cavity can be treated hysteroscopically. And how big can the fibroids be? Well, it really depends on the surgeon and their expertise. But things to think about is that the larger the fibroid, the more tissue and chips that one may have, dealing with both fluid absorption, visualization, chip management, and just difficulty keeping the walls quite distended. But fibroids can be removed in the intracavitary lesion. We can see here, as the size of the fibroid gets larger, the more time it takes to resect a fibroid via a hysteroscope. So this is showing that usually just a type 0, which is in the cavity fully, or type 1 are removed hysteroscopically. The type 3, 4, 5, 6, and 7 obviously would not be treated with a hysteroscope. And remember this high school equation, because size does matter. And a 1 centimeter fibroid has only about 1/2 cubic centimeters of tissue, versus a 4 centimeter fibroid has lots more tissue, 33 cubic centimeters. And so again, as surgeons, we must be cognizant of this to know that we have to deal with all the tissue, the fluid, and fluid management for safety. What about hysteroscopic outcomes? We find a high success rate for patients who have full resection of an intracavitary fibroid, up to 94%, very few failures. And again, when we look at multiple studies, after studies with different number of months of follow-up, that most patients have no further surgery when the full intracavitary fibroid is removed, and resolution of their abnormal bleeding. This is a great study just looking at how often it is that a surgeon can remove an entire fibroid. As we recall, a type 0 fibroid is fully within the cavity, and in this case there were 100 patients, of which 97% of the fibroids were removed. The 3 patients that are mentioned in the study, the surgery had to be terminated because of fluid absorption, and the doctors needed to come back a second time. Type 2 fibroids, again, only 61% of the fibroids could be removed completely, and often up to 40% of the time the patients required a secondary procedure. So knowing the size, the number, but also the location of the fibroids helps us to guide our patients in terms of whether this would be a 1-stage procedure or a possible 2- or 3-stage procedure in order to fully resect the fibroid. Likewise, this is pretty obvious, and it just says that the more fibroids that one has, and the deeper the fibroids are within the myometrium, as well as the size, that there may be slightly higher operative complications. Endometrial ablation is another option for women with fibroids, but a very select type of patient. So who is the patient that requires endometrial ablation? Well, it's a patient who has patient-perceived heavy bleeding or very disabling bleeding. Perhaps she doesn't respond to medical therapy, is a poor surgical risk. She wishes to preserve her uterus, and she must not want children because this is a procedure that generally is associated with destruction of the endometrial cavity, therefore making childbearing more difficult. The contraindications would be in someone who has hyperplasia, whether it's simple, complex, or complex with atypia, and obviously malignancy. If a patient has symptomatic uterine prolapse, that's not a patient who should undergo endometrial ablation. And a patient who has a large uterus, more than a 12-centimeter cavity, and if she has intramural fibroids that are greater than 3 centimeters, or fibroids with a large intracavitary component, they are not ablation candidate patients because of the location of these fibroids and the size of the intramural fibroid. If the patient has Mullerian anomalies, if she has adenomyosis, a prior transmural leiomyoma that's been detected, chronic pelvic pain, genital malignancy, acute pelvic inflammatory disease, and in women who are expecting 100% of the time never to bleed again, these are not patients who should have this procedure. As mentioned, this compromises childbearing, and so our patients who are interested in pregnancy should never have this procedure. As we know, right now in the U.S., there are about 4 procedures that are available, are ways to perform endometrial ablation. We can boil, we can burn, we can desiccate the fibroid, we can use a hot balloon to, to destroy the endometrium. And only about 1/3 of women who are treated with any of these modalities never has a period. What I tell my patients who are interested in endometrial ablation is that they should expect a return to normal menstruation. So only 1/3, as we look at the different ways of doing ablations, will the patient have symptom improvements such that she doesn't have any menstruation. We also have to talk with our patients about outcomes. What could happen following endometrial ablations? And so we know that this is not a permanent outcome, meaning no menstrual cycles. And some studies have been shown that up to 16, even to 35% of patients may require another procedure within 5 years. The biggest issue is the age at which the patient had the endometrial ablation. Younger women in this particular study had a 27% chance of having another procedure compared to women who were over the age of 45, in which only 10% had further surgery. Overall, 1 out of 6 women had further surgery after ablation, and this risk decreases with age. Why? Because as the patient approaches menopause and the cycles space out and they have oligoamenorrhea, their symptoms are going to get better. And the presence of uterine fibroid increases the risk of further surgery. So again, age is the strongest risk factor, with less than 10% of women over the age of 45 having further surgery compared to women under 35, in which 31% had further surgery. And what happens? Why do they have surgery? Well, they may have pelvic pain, recurrence of their heavy bleeding, both pelvic pain and heavy menstrual cycles, and at the time of surgery, specifically in the way of hysterectomy, you may find endometriosis in up to 68% of patients, fibroids in 64% of patients, and adenomyosis in 43% of patients. So all of the devices that are on the market, the longer we study the patient and follow the patient, they have an increased risk, especially when they're young, of having an additional surgery, i.e. hysterectomy. When we move into other types of surgery, now for patients, we're trying to move away from abdominal operations to more minimally invasive surgery. And what do we mean by that? These are small keyhole surgery, and we like them because there's less scarring, better cosmesis for the patient, less pain because of the small incisions, shorter stay in the hospital, sometimes as short as 6 to 8 hours or a 23-hour stay, faster return to normal activities, less pain, medications taken, less morbidity, and the cost may be less in patients who are able to go home sooner. So we're going to just talk briefly through different types of hysterectomies. We know that vaginal hysterectomy is the oldest surgery, and it is, even in 2014, the most minimally invasive surgery. It's also the least expensive and has better cosmesis because there is no abdominal incision. We find in average, again, size of the uterus may dictate whether the patient is a candidate for vaginal hysterectomy. It requires minimal equipment, shorter hospital stay, decreased pain, back to work sooner, and we also find overall an exceptional outcome even when we compare it to the laparoscopic approach. When we start looking at laparoscopic procedures, again, compared certainly to abdominal surgery, there's return to activity sooner, decreased abdominal pain, less episodes of being febrile or having unspecified infections, decreased hospital stay. When we look at quality of life indicators and questionnaires, at least at the 6-week and 4-month intervals, when compared to abdominal hysterectomy, better quality of life. It is a little bit more expensive because of the disposable equipment. It does require more training during residency and postgraduate or fellowship training, a longer learning curve, and when we compare injuries specifically to the urinary injuries, that there are greater risk from a laparoscopic approach of bladder and ureteral injuries compared to abdominal than when compared to vaginal approaches. Laparoscopic vaginal hysterectomy, or LAVH, basically, when we look at this, it's a surgical procedure that is done laparoscopically, and the upper supporting structures are all detached laparoscopically, including the uterine vessel ligation, cervical cuff dissection, and then the closure of the vagina is done vaginally. And so why might we consider that, or a surgeon consider that? Because it may increase the candidacy for a vaginal approach. This is very, very important when you're concerned about a nexal pathology or a lot of adhesions. So all of that can be freed up before the uterus is removed vaginally. LH, or laparoscopic hysterectomy, means detaching the uterine body from supporting tissue and ligating all vascular pedicles through the laparoscope. And again, closure of the vaginal cuff is vaginal. And this is very helpful also in women with very little uterine descensus or who have broad ligament fibroids, and improves the success of vaginal approach to the hysterectomy. Total laparoscopic hysterectomy, or TLH, everything is done laparoscopically, and it does require excellence in knot tying in order to do this all laparoscopically. Single port, or single incision laparoscopy, is a single transumbilical incision that's usually 2 to 3 centimeters. We now have multi-channel devices that we can detach all of the ligaments, treat the vascular system such that you can remove the uterus this way. Again, it requires excellent suturing ability, and you have to be able to understand the visualization of triangulation of the instruments. And again, it's a newer approach, and some of the centers in the U.S. are offering this to patients. The cost is greater because of the types of instruments that are used. Now, we've all moved into or hearing about robotic surgery. Just think 3 years ago, only 0.5% of hysterectomies were performed robotically. Now, anywhere from 10 to 15%. Well, what's the questions and concerns? Well, the robot's very expensive. It's about $1.7 million per robot. There is a maintenance fee of $125,000 annually, and each surgery, some of the single-use instruments may cost up to $2,000. Again, looking at the robotic hysterectomy, it is a laparoscopic approach. It does allow a surgeon to have 3D high definition with 10-fold magnification with improved visualization. It's great because there's less tremor. It's easier to do knot tying, but the physician loses the haptic feedback as the surgical procedure is done. The physician is at the console, so you really have to have a great bedside assistant and surgical team to help with that. And it's been stated that if all hysterectomies were done robotically, that we would increase the cost to the healthcare system between $960 million to $1.9 billion annually. So there's been a lot written and talked about robotic surgery vis-a-vis hysterectomy. And it's been said that robotic assisted hysterectomy offers no better clinical outcome than traditional laparoscopic surgery when looked over a 3-year period, with an average increased cost of $2,000 to the cost of the operation. ACOG, or the American College of OBGYN, recently stated that robotic hysterectomy is best used for unusual and complex clinical conditions in which improved outcomes over standard minimally invasive approaches have been demonstrated. So there's a lot of discussion about robotic surgery. I think it's here to stay, but we're going to try to find the patient that is best suited for this particular operation. We're going to talk a little bit about an emerging technology, also called radiofrequency volumetric thermal ablation of fibroids. Again, what's happening with this, it's a laparoscopic approach guided by ultrasound. It's an outpatient surgical procedure in which the tissue is heated and destroyed. So you have laparoscopy, ultrasound, and as we'll see in a moment, probe placement under ultrasound with RF energy in order to heat the fibroids and then decrease the size. And this is what that handpiece looks like. And it's deployed into the fibroids and heated under ultrasound guidance. What do we know from this outcome? Yes, there's a decrease in blood loss, an excellent quick return to normal activity within about 7 to 10 days, and a device-related adverse event of 3.6%. This is just showing also a decrease in fibroid volume of up to 40% at month 12. I'd like to talk with you next about medical options for women who have excessively heavy menstrual cycles, even in the presence of fibroids. One of the medications that we're happy to offer our patients is something called tranexamic acid. Currently, it's available in many countries over the counter, but in the United States, we now have an indication by the FDA for the treatment of cyclic ovulatory heavy menstrual bleeding, and it can be used in the presence of fibroids. The contraindications, just think about women who have contraindications to birth control pills. So we do not use it in women on hormone therapy such as oral contraceptive pills or Depo-Provera, or if they have had a previous history of an MI, stroke, DVT, or pulmonary embolism. In a clinical trial in which women were followed using the medication tranexamic acid, 650 milligrams every 8 hours for 5 days, we can see that within the first cycle or the first month of use, the amount of bleeding decreased significantly, and it sustained over 6 months compared to the placebo, in which there was no difference. So it is now considered to be a first-line, non-hormonal, non-surgical therapy for cyclic heavy menstrual bleeding. And the beauty of tranexamic acid is that it works quickly within 1 cycle and consistently over 6 cycles, with significant reduction in mean blood loss across all treatment cycles. I usually tell my patients, as listed here, almost 38 to 39% of patients will have reduction in their mean blood loss when using the medication. And that it also improved their quality of life outcomes so that they had less impact on the physical, social, and leisure activities. The levonorgestrel IUD has also been around for decades, but has now been shown to be helpful in the management of heavy menstrual bleeding without structural or histologic abnormalities, and also in the presence of small fibroids. Levonorgestrel can decrease bleeding by as much as 90%. Remember that it can take up to 6 months. Our patients just kind of have to stick with it a little while before it may work. And that each day it releases about 20 micrograms of levonorgestrel, and it's good for 5 years. Another great study using the alkaline hematine assay showing an excessively high amount of blood loss ranging from more than 100 mLs to 400 plus mLs per cycle, that you can decrease bleeding significantly in women who are using levonorgestrel. So there was a study that was done with about 67 women who had fibroids who decided to use a levonorgestrel for contraception. Their blood loss decreased by 84%, and with less blood loss, their hemoglobin and serum ferritin levels obviously increased. And by 3 months, 10 out of the 14 women who had also painful periods noted improvement in their symptoms, and the volume of the uterus and fibroids decreased. Only 6 of 67 women discontinued the levonorgestrel over 12 months. So this is another great option for women with a small uterus who have heavy menstrual bleeding and even cramps for use. What about GnRH agonists? It's been around a long time. FDA approved in 1999. As we recall, it stimulates the receptors and leads to a downregulation such that women are basically have very, very low estrogen levels and may have menopausal symptoms. It suppresses cell proliferation and induces apoptosis. And we also find that size of the fibroids decrease by 50%, such that fibroid-related symptoms, bulk, pressure, pain, bleeding, anemia, all of these things get better. What we have to remember is that usually we will limit treatment to 3 to 6 months, and many physicians will stop therapy. It may take up to 3 to 12 months before symptoms worsen again, and we may have use of the GnRH agonist episodically. The side effects that you would talk with your patients about are the menopausal symptoms such as hot flashes, night sweats, vaginal dryness. And when used for more than 6 consecutive months, there may be a decrease in bone mineral density. Another medication that has been studied is RU486. Recall that it is a synthetic steroid with anti-progesterone and anti-glucocorticoid activity. It's synthesized from a precursor norethindrone. It combines competitively with progesterone receptors and decreases prolactin levels in the leiomyomas and myometrium. There have been several phase 1, 2, and 3 trials looking at RU486 in various doses, and all tested doses decreased uterine volume by up to 50%, and also decreased size and improved quality of life indicators. And there was no evidence of endometrial hyperplasia. Again, theoretically beneficial, not currently available on the market for treatment. Next, I'd like to just talk about azoprisnol, another first selective progesterone receptor modulator that's been studied in the treatment of uterine fibroids. And what we know about this drug is that it inhibits the expression of growth factors within the fibroids, and inhibits the proliferation and also induces apoptosis of cultured leiomyoma cells. It reduces collagen deposits, and also in clinical trials, both phase 2 and phase 3, that it decreases uterine volume by up to 36% after 12 weeks of therapy, resulting in less bloating, pelvic pressure, and also is associated with follicular phase estrogen and minimal hypoestrogenic complaints, and it moderately reduced uterine artery flow. Another interesting study out of Europe last year was ulipristal. And what is this? It's a synthetic steroid derived from 19-norprogesterone. It is a selective progesterone receptor modulator that binds to progesterone receptors, and it has anti-proliferative, pro-apoptotic, and anti-fibrotic actions on leiomyoma cells. Both phase 1 and 2 trials have been completed, and as expected, it reduces uterine volume, controls bleeding, and thus improves quality of life. In France, a great study by Danez looked at both ulipristal compared to women who took varying amounts, but we found at week 13 that ulipristal controlled bleeding in 91% of the 96 women who received 5 milligrams a day, and it also decreased uterine volume by up to 21%. When compared to women who took 10 milligrams per day, the bleeding improved by 92%. And compare this to women who took placebo, in which only 19% of the women had improvement in bleeding, and they also had 3% of them had increase in uterine volume. So when we look at all of the things that we talked about today, we find that the fibroid size, number, and location will often determine clinical symptoms and treatment options. It's important for physicians to speak with their patients about different clinical care pathways. It's important to talk about what patients want. Are they interested in children? Are they interested in medical or surgical options? It's important to have a collaborative practice with interventional radiology, especially if your hospital offers both UFE or MRI-focused ultrasound. And I think the concepts that are integral to the Center of Excellence, where you have great teams working together, will improve the outcome of the patients we serve. Thank you very much.